Zhang et al. Have previously published research on comparative effectiveness between PCI and CABG. Well, now they're taking a look in the issue of JACC for January 6, 2015 at the issue of costs. And we're talking with John Spertus, who is MD, MPH, and the author of Asserting the Value of CABG in Stable Angina Patients, the Challenges and Potential of Observational Research to Improve Care. This is the editorial comment. And Dr. Spertus is Director of the Health Outcomes Research at St. Luke's Mid-America Heart Institute. Now, ASSERT is a collaborative effort. So first off, let's talk about ASSERT and just what that is.
So ASSERT really is a major step forward for the American College of Cardiology and the Society of Thoracic Surgery to combine their databases. And they both have, for well over a decade, almost 2 decades, have been collecting data on all patients undergoing revascularization procedures. Into ACC, it's been angioplasty. At STS, it's been bypass surgery. And they've been tracking the care and outcomes of providing those treatments to their patients. But obviously, patients often face a choice where, some patients may prefer bypass surgery, some may prefer angioplasty, and there's been a paucity of data to compare the two of them, and the real-world experience gathered by these two registries and partnering together to be able to help understand the outcomes of patients is really a terrific advance.
Well, in your commentary, you call the work by Zhang and colleagues a statistical tour de force.
Well, so with observational data, it's very challenging to, in a clinical trial, you can randomize patients to treatment. And when you do that, you are quite confident that however the groups may sort of differ, it's sort of random, and that the main thing that differs between the two groups is what treatment they got, and if it's randomly allocated, then any difference that those two groups experience can be attributed to the procedure. In observational data, it's very different because patients, either because of their preference or their physician's preference, are getting angioplasty or they are getting bypass surgery, and you can't compare them because the treatment is not randomly assigned, and the difference in outcomes may be due to the patient selected for or who choose angioplasty, or the patient selected for or who choose bypass surgery, and not due to the treatment at all. And so what they've had to do is to do an awful lot of work to first restrict the patients to patients who theoretically might be eligible for both procedures, and that was stable coronary disease with 2 or more vessels blocked. Then they had to further restrict it using the data available in the registries to find similar patients. And they'd used a very fancy statistical method called propensity scores to do that, but the net result is that about 90% of the patients were excluded from their analysis. And so for the 10% of patients that sort of look like they could go either angioplasty or bypass surgery, that's what we're comparing. And then to make matters worse, these propensity methods only work if if all of the things that go into the propensity score that are important in determining care and outcomes are actually captured in the registries. And in these registries, there are very important issues like, the surgeon said the patient's too sick to do bypass surgery on, and the angioplasty guys get stuck trying to help that patient. That can't be adjusted out of the analysis. So it is a challenging thing. That said, it is very naive to think that we have to do randomized controlled trials for absolutely every possible decision in medicine. And so we need a lot of judgment and a lot of care to leverage these kinds of data. And their original publication from the ASSERT in the New England Journal of Medicine looked at mortality as an outcome, found greater survival at 30 days with angioplasty, no difference at a year, and greater survival with bypass surgery at 4 years. But now they've extended that in the patients over 65, that they could start to look at the costs of care from Medicare's perspective. And that's what they've done here. And while it is a statistical tour de force to find like populations, to be able to link to Medicare, to study the long-term outcomes, to add costs into that equation, I mean, it's very, very hard to do. At the end of the day, it's a little challenging to know how we should apply and use that data, because frankly, all the limitations of the original publication still hold, and now we've added on additional layers of complexity.
So given their overall results, the CABG is more expensive, but probably a reasonable value. What are clinicians and policymakers to do with this information?
Well, so currently in the way that physicians interact with patients, we don't really have cost be a major consideration, especially the cost to an external payer like Medicare. You know, patients will tell us, it is cheaper for me to be treated this way because of out-of-pocket costs and coinsurance, and we will take that into account because it's the patient's concern that we're trying to address. We don't have a mandate and we don't have a practice of worrying about whether Medicare is going to spend a little bit more or not. Now, Medicare cares a lot about that, and they clearly want to invest and encourage treatment where there's a good value. And here, there is a reasonable value to bypass surgery, but I think that's still has to be secondary. So from Medicare's perspective, it is probably a reasonable value to pay for bypass surgery. It is less expensive to pay for angioplasty, and there's no compelling information one way or the other that one is clearly better than the other, so that Medicare should probably be very comfortable not meddling in this decision-making process and letting physicians and patients work it out themselves.
You obviously have talked about some of the issues you had with the analysis. Big data is only going to get bigger, as will all the arguments as to what we do with it and how we manage it. What can we do to feel more comfortable with what big data is telling us? Because it's not going to go away. We're going to have more data coming from trials like this.
So I like big data. I mean, I work in big data. I'm humbled by how complex it is to analyze the big data, and not so much the technical aspects. I mean, I think a lot of our residents and fellows could get a big database and start doing random, crosstabs and trying to extract information from it. So there's a lot of need to design your questions very carefully to make sure you have all the relevant data that could influence the process you're studying. And to that extent, ASCERT did a very good job. We also need to think about making the data even bigger by augmenting our current data that may be easy to collect with data that's important to collect. And in this example, one of the most important outcomes from bypass surgery in stable coronary disease or angioplasty in stable coronary disease is the improvement in symptom control and quality of life that patients get. And that requires additional data to be collected that is not part of any normal data set. It's not part of Medicare administrative data sets. It's not part of our registries currently, although the TVT registry, the percutaneous aortic valve registry, is starting to collect quality of life data as part of the routine process of collecting data. We need to start doing that in coronary disease and peripheral vascular disease and other conditions so that we can understand how our treatments are impacting patients' symptoms, function, and quality of life. And so I actually think data needs to get better and bigger and be infused with what's really important to patients and to doctors trying to provide the best care for those patients. And that's something we really need to be spending some effort thinking about, not just what data can we get that's easy to get, because we could get overwhelmed with lab data, administrative billing code data, pharmacy data, because that's all electronic, and pulling that together, while difficult, is relatively easy. But if there are important things we need to inform practice, we need to figure out how we're going to start collecting those.
I think the big data issue for many physicians particularly is if you've got some concerns with a well-controlled trial, once you start opening it up to much bigger databases, all these issues just become bigger and bigger. And so it's scary to kind of sit there and go, so how much faith do we have in this data?
So I think what we need to be doing is rethinking the way we do guidelines, for example. I mean, guidelines, the clinicians have grown comfortable basically absolving themselves of having to critically read each of the myriad of papers and trusting a very well-vetted process of professionals to review, weigh, and balance all the different disparate trials and data in order to be able to come up with recommendations. We need to start thinking about, can we develop prediction models of patient outcomes that would be useful in clinical care, and can we create an infrastructure within the ACC, within the AHA, perhaps collaboratively, including STS, to start to figure out what are valid, useful, important prediction models that could improve care so that we can start delivering personalized medicine today and start informing patients not in an abstract, vague way about how they're likely to do with one treatment or another, but given their conditions, their age, their diabetes, their coronary disease, what can they expect if they choose angioplasty or bypass surgery? And this would apply to everything, and that requires having enough expertise to know that these models are important, they're valid, the big data from which they came was the right data for that kind of analysis. And if we could start to maybe move from guideline summaries to basically embracing certain models as being informative and helpful in clinical care, I think that'll take us a large step forward and really allow big data to not become a big nuisance, but to become very useful.
Well, to kick off the new year, this is a very interesting pair of papers. Dr. Spertus in his editorial comment and the original paper by Zhang et al. Please check out the January 6th, 13th issue of JACC, and for Cardio Source World News, I'm Executive Editor Rick McGuire.